Northern Zone second CPD activity for today. This is the second CPD training we are doing for the zone. And I am Felicia Danso. I'll be leading and hosting session. Today's topic for discussion is indigenous foods, using indigenous foods in the management of non-communicable diseases. And to do this presentation for us, we have none other than our own Professor Paul Ama-Ayi. He is a lecturer with the University for Development Studies, School of Allied Health Sciences. I mean, he's not a new person to many of us, but to those that may not have encountered him in any way, he is a pioneer, the School of Medicine, School of Medicine and Health Sciences, UPS, in the very early stages. That was before the Allied School of Allied Health Sciences was. And he continues to be a very important person in the nutrition in. You hear me? Please, am I being heard? Hello? My line is gone off. Someone. Network. Hello? Hello?
Oh.
Hello.
Hello, we can hear you.
Can hear you.
Yeah.
Okay, all right. Thank you. So we have Professor Paul Ama-Ayi. And then please do bear with us if the internet breaks. Bear with us if the internet breaks. The connectivity is not very strong from where we are. And if you, I would just encourage that you mute so that we can hear ourselves. And if you have any, and then I can give you the opportunity to share your view. So we will begin. Inviting Prof. Ama to join us.
There's a lot of.
You can use your.
Can you hear me? So that I can then start. I'm not hearing any response. Hello?
Hello? Hello? We can hear.
Okay, all right then. Thank you. Thanks for that. Yeah. Okay, I think just a few inputs to what Felicia just said. That the program we are having, or the event today, is supposed to be a workshop. It's not just a Zoom presentation or PowerPoint presentation. It's supposed to be a workshop, and I know that in a workshop we will facilitate by making presentations and then there will be a period for interaction, for us to interact, so that we get a better feel of what is going on. It would have been very nice to have everybody face to face, but here we have to make do with the Zoom because most of our members are not here in Tamale. So we'll try and manage. Unfortunately, the internet is not very stable. It's just rather unfortunate. If we had used the previous place, I mean the previous residence or previous office that we used, I'm sure it could have been better. But nevertheless, we will still make the necessary forward march. As you've been told, the topic that we were supposed to look at, the workshop that we're supposed to have, is using indigenous foods to manage or manage non-communicable disease. Now, if you are going to talk about non-communicable, I mean, using or managing non-communicable disease, it is very important that you know exactly what we are talking about. What exactly is what we are referring to important, because all know what really it is. Perhaps we need to have a fair idea of what it is, and then maybe what brings about non-communicable disease. And then when we have known all this, it will then give us a very important idea as to how we can nip it in the bud, or how we can manage it or control it. There are going to be a lot of very profound statements from my end because of my knowledge of this particular subject. I teach it and I virtually expound it wherever I go to. So maybe you need to sit back and hold tight, because I'm sure there will be a lot of things that you will hear from me today that perhaps you have never heard before. And I'm sure there are a lot of you who know even something more that you may want to add to this particular topic as we go down the memory lane or go down the knowledge lane as far as this topic is concerned. When we say non-communicable,
I don't know if we can all still hear Prof, but hello, Prof.
I can hear Prof from my end.
I think he's muted. Prof, please, if you can hear me, your microphone is muted.
Oh, okay, sorry. Sorry, oh. This is born before
Okay.
computers.
It's
I
okay,
hope you
Prof.
understand what I'm saying. Okay.
Very well.
Yes, I was trying to give an overview of what non-communicable diseases are. And I was also saying that if you look at the way the topic is presented, it also presupposes that there are communicable diseases. Also, the fact of the matter is that we are talking about non-communicable diseases because they happen to be the most prominent, the disease most predominant in the causation of ill health, in the causation of death, and so on and so forth, of causes that may, giving you problems, conditions that that creates a need for long-term treatment and care, because they are long-lasting. Chronic non-communicable diseases are long-lasting. In other words, they take a long time, long duration, and they are, that is the simple meaning of chronic. And they are all chronic, even though sometimes in some definitions they add chronic non-communicable diseases. But if just to say non-communicable is enough to consider it as a chronic disease, long-term, long-lasting, and so on. And because they are long-lasting, they often will need treatment and then care. And they do not start at the time that you think they have started. They are long-lasting, and most of the time they start very early when they cannot even be detected. And even in adult stages, sometimes you do not find people with any chronic diseases. It is only when the chronic disease begins, then they now see, oh, he has this condition or that condition. Very often it is subtle. They are underground. They are subtle. And we'll begin to understand why they are like that, because of their origin. Now, the results, the non-communicable diseases result from a combination of so many factors. There are so many factors that are integrated, or that interplay to bring out non-communicable. That is why it's so difficult to exactly put to put your finger on a particular thing and say, this is the cause of it. There are so many things together. And that even makes it, that is, in fact, it's the main reason why they are lumped together and called non-communicable, because a number of conditions, and they interplay because one condition will influence another condition, and another condition will influence another condition, and so on. So you may have the onset may be one particular condition, but it then triggers another condition, which triggers another condition, and so on. So in even a particular individual, you can have a number of the diseases together. It's not just one. And I'll give you a typical example. Somebody suffering from heart attack or cardiovascular diseases may not just have cardiovascular disease that may be the main thing that you see, but underneath it, there are so many other things that can be identified. The person may have some other, maybe obese or overweight, all kinds of other conditions are called non-communicable. They kind of cascade into each other. So it's very, very important for us to recognize this fact. And that is why in our bid to learn how to control this condition, we need to know all the facts concerning it so that we don't use that normal one-prong approach. Let's do this because we think this is the cause. There are maybe a number of causes, etiological connections. Now, no, hold on. They result from a combination of, now when you read the textbook, you tell they result from a combination of genetic, physiological, environmental, and behavioral factors. the people have identified these as the major causes of these non-communicable diseases. Now, if you look closely at these conditions or factors, you will see that underlining all these factors, there is something that has to do with nutrition. And I want to say this early so that you get things right. There is something underlying all this that has got a pointer to nutrition. And when I say nutrition, please, I want you to get it clear. Anytime I mention nutrition, I'm not talking about just diet or foods. I'm talking about the holistic aspects of nutrition. And some of you may not even know that, for instance, physical activity is associated, is a nutritional feature, physical activity. So if you are not undertaking physical activity or you are inactive, it is a nutritional issue. I want you to get clear. So all these, and that is why many of them, about almost 98 or 99% of the non-communicable disease are diet-related, or so rather nutrition-related non-communicable diseases. So we talk about NCDs, many other times we are talking about nutrition-related NCDs. Even those that are not nutrition-related has some connections with nutrition. For instance, if you are talking about accidents, trauma, no, those are also non-communicable diseases, accidents or trauma and the rest, those things, okay? They are non-communicable. I can give you some others, and they are all usually related to nutrition. And we'll come to that as we go along. Next slide, please. Now, they are largely, because they are nutrition related, they are largely preventable. I'm sure you will see somewhere people talk about modifiable factors and non-modifiable. For what I stated earlier, the 4 factors you are seeing, some are modifiable and some are non-modifiable. In fact, in the case of some of them, the modifications are the primary onset. They bring about the non-communicable. They are modified from the beginning and set up the non-communicable diseases. And some are very difficult. They are non-modifiable because once they have altered, their condition has been altered. It's difficult to re-modify or re-alter it. And that's why you see that a huge number of them are actually modifiable instead of non-modifiable. Even the non-modifiable ones, if we now look at the underlying cause of non-communicable disease, there's a tendency that we can modify them before they even happen. We can do something about them before they cause the non-communicable disease. Therefore, they can be modified from a certain state, and we'll begin to understand this, whatever it is. Now, they also have what we call a shared risk factor. They have shared risk factors. Sometimes these are classified under the modifiable and the non-modifiable factors. Conditions. We have, for instance, the shared risk factor communicable can lead to most of these considered by and largely as factors that can be modified. We have tobacco use, unhealthy diet, physical inactivity, and the use of alcohol. You can see all together, you can see that these are things that you can largely put under nutrition. Tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. Now, these conditions or these factors were identified by people who were epidemiologists or who were public health, know the in-depth or the nitty-gritties about how these things come about through nutrition. But you can see unhealthy diet is captured there. For me, it's just when you say unhealthy diet, there are things that go beyond diet. So you see, and all those other aspects of tobacco use, physical inactivity, I've already told about physical activity, and harmful use of alcohol abuse, for instance. All these can be captured in nutrition because they are part and parcel of our nutrition. Tobacco use is clearly something that goes into your body. You are smoking and it's going into your body. So it can be considered in that direction. And we'll talk about that as we go along in the larger setup. Now, they are a leading cause of death, non-communicable disease. Well, leading cause of death. They cause about 71% of, so many millions of deaths that occur. That small percentage that we are looking at will be probably so communicable diseases. That's very huge. The contributors to death, to ill health, morbidity, and mortality. Very, very huge, 71%. So now in our country, in Ghana, in our setting, non-communicable diseases are contributing to a large number of deaths. In Ghana, hugely, most of the deaths that occur in our hospitals are due to non-communicable diseases. But, we do not want, when we classify them together, it's important to look at them because they all have similar connections. Like I said, their etiologies are really, really related. And we see them as we go along. Now, the majority of these deaths are attributed to one. The first on the list of the non-communicable is the cardiovascular diseases. The cardiovascular disease include the heart, disease of the heart, disease of the vessels, the blood. You talk about vessels. We are talking about the cardiac, what do you call it, vascular diseases. And there are many of them. There are quite a number of them. I think this is not the time to be mentioning them, but as we go along, I'm sure some of them will come up. Then we have diabetes. It's an endocrine disorder. Diabetes is an endocrine disorder of the pancreas. And we know it's very, very common, in fact, cardiovascular diseases are leading, followed by diabetes. And then sometimes cancers, the various type of cancers are coming up. Then we have the chronic respiratory disease. In fact, these conditions are once or the other times, they are competing with each other in terms of their contributions to death. Sometimes cancers will become overwhelming, they overtake one of the other diseases and so on and so forth. Currently in Ghana, we know that cardiovascular disease are number one, and I think diabetes is chased. In fact, these are the four main ones. It doesn't have the only ones, and they are linked together. If you are not careful, you get diabetes, you make cardiovascular disease. You get diabetes, you can get cancer, and then you can get something else. If you get a chronic respiratory disease, it may lead you to cardiovascular disease, may lead to diabetes, may lead to cancer, and so they are intertwined because of the conditions that predispose them. Now, we also have others that are majorly coming up, and we may not recognize them right now, but even the neurodegenerative disorders like Alzheimer's disease, dementia, in fact, depression is a non-communicable disease. Then we have those that are associated with the various, cancers, the various, conditions that are very, very serious and lead to a lot of debilitating illnesses and death. Now, obesity and overweight, hitherto were not thought of as these diseases. They were thought of as conditions that were came out of affluence or wealth. You are wealthy, but it is very obvious from the way they are related or associated with most of these diseases that they are also non-communicable. So when you are overweight or obese, consider yourself as having an underlying non-communicable disease. And most at times, more often than not, these diseases will cascade you into any of these others that we have just talked about. Epilepsy is now, in fact, asthma, respiratory tract infections in particular, in children and in adults, and so on, are all non-communicable diseases. We need to take note of that. In fact, there are a lot. There are over 40 of them. Even in Ghana, there are some of them that we may not consider because we always look at them from a different angle. sickle cell disease, thalassemias, name them. There are a number of them. These were thought to be, genetic oriented. You remember from the beginning, I told you these factors that relate to each other, that contribute together to bring about this non-communicable. So you may think of them as genetic, it may be physiological, they may be, biological or behavioral and so on and so forth, but they contribute, they all bring up the underlying condition of non-communicable disease. We need to be very wary of them. In fact, there are also behavioral risk factors. One, you see, the behavioral risk factors are so inundating, they are so large that sometimes you don't even know where to place them, because most of the conditions that really bring about cardiovascular disease, diabetes, cancers, and respiratory disorders has to do with our lifestyle, which is essentially behavioral. Your lifestyle is essentially behavioral. That's why they are also classified under the modifiable things. Now, tobacco smoking was known to be number one, but I think in Ghana in particular, mostly is the young generation, the young children. Most adults are stopping the smoking of tobacco, and it's not even a problem, nationwide. But it is still a contributor. And the funny thing is that it's not even the primary smokers, even the secondary smokers. If you go and pass anywhere or stay in a room where tobacco has been smoked, you are going to smoke the tobacco, and it's likely to lead to one of these conditions. The physical inactivity has been known. It has been known for a long time to be a big problem associated with non-communicable diseases. Physical inactivity, which is always described as being sedentary most of the time. Your lifestyle is, when they say you are sedentary, what it means that you are not expending energy as much as you are taking in the energy. You are eating foods that will provide energy, but you are not expending it. That's why I was telling you earlier on that physical activity is a nutritional issue. If you eat or you take in energy, you must expend energy. Expending energy is not about exercise, it's about physical activity. When you are eating, even at the process of eating, there's some of the energy which is being dissipated as part of the activity. Basal metabolic activity plus physical activity. Basal metabolism is the basal things that undergo activity that you undertake whilst you are at rest, and the rest of it is physical activity. As I'm speaking right now, I'm engaged in physical activity. It's not the vigorous exercise type, something I should be doing most of the time. When you walk, when you are, sweeping, when you are singing, but all those are physical activity. They are in a certain category, but you need to also expend some of the energy depending on how much you have taken in the form of, doing things that will increase your energy expenditure. Otherwise, chronic diseases will take over to help you to expend that energy. So one of the issues of accumulating energy will lead to non-communicable chronic infections, chronic diseases. So we should take note of that. Too much of energy is going to lead to whatever it is. Then unhealthy diet. Yet again, I question the issue of diet. It's unhealthy nutrition, poor nutrition, bad nutrition, not just diet, because nutrition goes beyond diet. And when I say diet, I'm sure the dietitians will tell you what a diet is. They will define diet, and diet is usually about food intake. But nutrition is not just food intake. Even the physical activity I've just described is nutrition, because you have to take in the food, expend some of it. It's very important that you expend some of the food, and all that is part and parcel of this. So how you take it and how you expend it, when you take it and when you expend it, all those things go into all these various aspects of nutrition, so that if you don't do it properly, appropriately, your organs are not appropriately tuned to do these things for you properly. They go into this state where they accumulate, and then they give you these problems we're talking about, non-communicable diseases. As for the respiratory diseases, chronic respiratory disease, they are also connected in this very way through environmental problems of pollution, and so on and so forth. Nutrition also under being part of it, and so on and so forth. It's very, very important that we look at it. These are generally grouped under 4 main things, but there's one thing that is missing, and I would like to say it here before I go on. Otherwise, we will not grab it. It's very difficult. It has not been stated in a lot of books that are they have not considered or the beginning, the genesis of the non-communicable disease, because that was the period by which a lot of communicable diseases started showing symptoms and signs. But evidence is now accumulating to show that the non-communicable diseases we are talking about start even before you are born. That is, start during conception, when you are in your mother's womb. The conditions in the mother's womb during pregnancy and the conditions during the first 1,000 days, including the 2 years of life when you are born. That's pregnancy plus 2 years of life is equal to 1,000 days. The conditions you undergo during that period, including the nutritional insults, including environmental factors, including all the behaviors your mother is undertaking, all the factors that I've described earlier, are very much the predisposing factors to non-communicable disease. So if you start having non-communicable disease at an adolescent or adult, even in a child, in the toddler stage or childhood stage, it most likely started earlier when you were in the mother's womb. And this is evidenced by what we call the developmental origins of health and disease, the Barker's hypothesis. And a lot of people are now beginning to see how important the concept is as far as non-communicable diseases are concerned. We need to consider it. And for us in the Africa, where we do not joke with our children's nutrition, our pregnant women and children's nutrition is very important to reconsider. Otherwise, these emerging epidemics of non-communicable cannot be nipped in the bud. We need to go down back there and all these burdens that we are seeing right now. It's rather on the increase. And you agree with me, cardiovascular diseases and all the kidney problems, diabetes, and all these that I've been mentioning are on the increase. They are rising very fast. Obesity and overweight is rising very fast. And all these start, like I said, from the beginning. We need to go back to basics. The leading risk factor that has been accepted globally for mortality is the race. These are all risk factors actually associated with the non-communicable diseases. And you'll see that they zoom into what I've mentioned earlier on about some of the factors that are considered either modifiable or non-modifiable. The leading risk factors are the raised blood pressure, which we talk about as what? Hypertension, okay? Hypertension, responsible for a certain percentage of deaths globally. Okay, hypertension is just one aspect of the cardiovascular disease. We have tobacco use. In fact, I don't know why I even wrote it here. It's not a very important aspect here in our parts of the world here in Ghana. We'll look at it later on. It's very common in those countries where it's being allowed. Even now they are clipping on it because they have found out how tobacco use can affect a lot of, can create a lot of these conditions. Raised blood glucose, which is basically what leads to diabetes. Raised blood glucose. Physical inactivity, leading to sedentary lifestyles, obesity, overweight, and then all these are, causing a lot of problems, a lot of issues, a lot of chronic non-communicable diseases, and they are leading to deaths. As you can see, overweight and obesity is one of the important things that we are looking at of late. You can see that there's a lot of work on overweight and obesity, and our waistlines are being watched. You have to watch your waistline as it is growing. Sometimes we are ascribing to wealth. Somebody is growing fat, and then they say, oh, he's doing well. He's now getting plenty money. look at the fatness, look at the cheeks and so on. But that is something that has the potential to cause morbidity and mortality. So we need to be very careful about that. Can I have the next slide? Right, now, basically, just to give you a fair idea of what cardiovascular diseases are, they are caused by disorders of the heart and the blood vessels. Cardiovascular disorders of the heart and blood vessels. And you know, the heart, the blood vessels supply various organs of the body. So if you have a disorder of the blood vessel, it could be, you know, just a particular organ or various organs in the body that it supplies that may be at the receiving end of it. Now, if the blood vessels are, for instance, in the brain, you can have trouble with the brain to lead to what we call the strokes. Okay, sometimes the medical parlance they describe as cardiovascular accidents, strokes in the brain where the rupturing of vessels or sinuses lead to flooding or, you know, movement of blood into other spaces, and therefore reduction of blood supply to the brain tissue and so on. In the heart, you can have a similar problem. The vessels of the heart, which are called the coronary vessels, can be affected. And when they are affected, they can also rupture or they can be blocked. And when the tissue of the heart itself will not get blood, and that will lead to death of the heart tissue. So all the conditions we call infarctions, myocardial infarction, conditions that affect the heart tissue itself. And sometimes the lining of the heart tissue is also affected. The lining of the endocardium can be affected. In fact, with the vessels, it is the lining of the vessels that get affected first. They get the import of the causation of non-communicable disease. We'll come to the causation very soon, but I need to explain to you what these conditions are and how they are very important. There are so many. In fact, in the medical parlance, they are described in so many ways. Some of them are embolisms, thrombosis, whatever. You know, you get all sorts of things. I'm not here to bamboozle anybody, but I know in your reading you come across a lot of these, and you will know that these are non-communicable diseases. Some of them are congenital. Congenital is that when the mother, your baby is in the mother's womb, they come about when the baby is there, is being developed, or the baby is developing. There are conditions associated with the organogenesis and all the complexities of formation of organs while the baby is in the womb, first, second, and third trimester, and also during the time the baby is born, the first 2 years. Now, the period of the 1,000 days, it's when these changes can occur. It's called the plastic stage. The plasticity of the 1,000 days, the plasticity of development in the baby is said that when things can happen, can change certain conditions, certain structures. And when this happens and it's not reversed, that is where you know that then you are heading towards trouble. So organ formation, organ development, you know, as a result of these conditions, the causations, the environmental risk factors, and so on and so forth that I've described, can lead to changes. And when the baby is born, and by 2 years, not reversed, the conditions become permanent. And gradually you are getting into that stage. Childhood obesity, adolescent obesity, adult obesity, and all those things they start from there. They start right from there. All obesity and diabetes, juvenile onset diabetes, maturity onset diabetes. All these conditions. And when I say diabetes, I'm not talking adult type 2 diabetes alone, even though that is what is being recognized. Type 1 diabetes, which is an autoimmune disorder. In fact, for the immune disorder to occur, it means something has caused it. And these causations are what the conditions that we are going to be looking at. So even autoimmune disorders are non-communicable disorders. We need to look at it from that perspective, and that is the truth of the matter. I know a lot of the time, epidemiologists shun away from looking at the nutritional import of some of these issues we are talking about, but they are very, very critical. If you leave away the nutrition bit, then I'm thinking that you are That is why we are not able to nip non-communicable disease in the bud, because we are considering curative measures, how to cure it, how to prevent it at an adult stage. And when you do that, you are only ameliorating the condition. You are not preventing it. You are only retarding this. You are slowing down the process of the condition. But we need to root it from the it is when it starts. Think about nutritionists, that is where the problem is. The nutrition from the foundation is not good. And when nutrition from the foundation is not good, you get all these problems in the latter years of life. So we need to put ourselves into the frame of things and look at it from that perspective. Otherwise, overcome by these non-communicable diseases. They are already increasing in droves, in large numbers. Now, cardiovascular disease is just one, and I can tell you about a whole lot of things. The next is the cancers. We look at cancers. The next one is the cancers. The cancers are so many, females and males alike. We have several different types of cancers which are coming. They are non-communicable diseases. Let me say them again. Non-communicable diseases, cancers of the bowel, cancers of the breast, cancers of the uterus, cancers of the cervix, cancers of the prostate, cancer. All the cancers you can think about, they are coming from this, what I'm doing. They are non-communicable diseases that are caused by these conditions, underlying conditions that we've talked about. The risk factors are there, clearly. So somebody is getting prostate and you don't know where it started. It started a long time ago. Somebody is getting breast cancer and you don't know how it's come about. It's come about because of the conglomeration, the meeting of several factors which were not taken seriously right from the beginning, right from the mother's womb, and when they are children, and when they are adolescents, and so on. And then you exacerbate, you increase the condition, and it has that effect. The chronic respiratory diseases, asthma, when children are, growing, that respiratory diseases are upper respiratory tract infections and so on and so forth. They are infections, yes, but they become chronic. And when they are chronic, they lead to the other conditions, the chronic respiratory diseases, disorders. Now, the ones that occur in utero is the one that leads to poor formation of the lungs, malformation of the lungs as a result of nutritional insults. When your lungs are not properly formed, already you are poised for a problem in adults. When your lungs, it's not just lungs, I'm talking about all the other organs, even the heart, even the GIT, even the kidneys and all that. So right from the inception of the human being, the sectional stages of your physiology, that's why we say physiology is very critical. If the physiology goes wrong, then something is going to happen somewhere along the line. So your organs are not laid properly. You don't have good heart, good pancreas, good kidney, this and all those things. Then by 3 years or 2 years of life, the problem is still like that. When you are giving a little bit of, an increase in the conditions we are talking about, the environmental conditions and so on, when you are under that stress, immediately you are going to succumb to it, and these conditions will start showing. These problems of non-communicable will start showing their head, rearing their ugly head. So it's very, very important that we consider all this and know that it is not what we see in adult life and so on. When you see it even in children, you have to start looking at it and trying to nip it in the bud before it gets into a stage where it then reoccurs again. Most of us are suffering from some of these conditions because nobody was taking, precautions about our conditions when we were children and when we were in our mother's womb and so on. All the insults that our mothers. The last time we talked about anemia, for instance, I'm sure there were a lot of you now saw the dimensions of anemia that you never saw before. And these are some of the issues. Anemia is caused because you are having non-communicable, underlying anemia is a lot of non-communicable, chronic inflammatory conditions. We'll come to talk about what causes the non-communicable, and the diabetes is there. It's a chronic disease that occurs when the pancreas does not produce enough insulin, or the insulin that is produced is not responded to effectively. So you can see that there are two ways. I mean, it's an endocrine disorder, and that is not the only endocrine disorder that you have under non-communicable disease, but because it's a major, when you see how your body regulates the importance of glucose and how it is regulated in the body is so important that without it, you can have these conditions emanating as what do you call it, diabetes. There's also another type of diabetes. I always mention it because of I'm a physiologist. I was like, but it's also a non-communicable disease, but it's not very common. It's called diabetes. Now, obesity is something that when I talk about, people look at them. When you are obese or you are a little obese, because there are classes of it. When you are first grade obese, it's like a beauty. It's like, okay, yes, you call it, they have a name for it. They say what plus, something plus, yes, XL or X plus something. So, yes, they have plus size, plus.
I think, Prof, your microphone is muted again.
Metabolic syndrome, because the metabolic.
So Prof, for what you said in the last 1.5 minutes, we didn't quite hear. Your microphone was muted. If you don't mind repeating it, especially from the plus size comment.
Yes. So,
It appears that Prof's network is unstable right now. I'm sure he will join us again. In the meantime, if you have questions, you could put them in the chat, and then we could show them up when he comes. Read them when he comes.
hello. Hello.
Yes, Prof, we can hear you now. Welcome
Hello.
back. We can hear you now, Prof.
Okay.
Welcome.
All right. Then let's go. We're talking about the obesity. Thank you very much. Okay. Obesity and overweight is also a condition closely related to obesity, and they all have various. They have the similar causations or similar consequences. So when you are overweight, it means you also have underlying, problems or factors, and that obesity or overweight is a chronic, non-communicable condition. You need to be careful, otherwise, before you know, it has culminated in other non-communicable diseases, predisposing you to diabetes, predisposing you to all those other conditions that we're talking about, the others that we have mentioned, cardiovascular disease and so on. So it's no wonder that when you have one of the conditions, before you know, you are also developing the others. So we need to be careful. They are so much interrelated, including epilepsy, including all the others. But the underlying fact is that they start from the womb. They start from the womb. That's what I want to state today, emphatically. If you don't get anything at all, take it from me that I'm saying non-communicable diseases start from early stages of development. That is the womb. And that's the period when things happen. Now, yes. Now, non-communicable diseases, currently, we say that they are, yeah. We say that there is a, okay. No, let's go back. I just wanted to, just a little, yes, go back small. Okay. Yes. No, the current state talking about it is a very, conditions, or there are conditions that are killing everybody. It's killing us. Yes, this is where I was. Okay. All right. So this is the sorry, what is this? Hey. Time is okay, all right then. Okay, so in fact, non-communicable diseases are so rife. I want to emphasize, and they are causing millions of deaths and diseases. And the important thing about it is that because they are nutrition related or diet related, if you want to put it that way, they are preventable. They are usually caused mainly by the modifiable factors. So they are preventable. You can prevent them. And also, from what I've said about the fact that you can track them down from their onset in the mother's womb in the first 1,000 days, you can still prevent them from there. You don't need to wait until they begin to show themselves, where we now begin to institute secondary and tertiary preventive measures. In that situation, the problem would have escalated, because remember, they are coming from left, right, and center, from different conditions in the back, right? Even get to that stage. And that is why the deaths and the morbidities are escalating every year, year in, year out. Even when preventive measures have been put in place, singular, unipronged preventive measures cannot stem the tide of non-communicable diseases, because they are coming from different. When you look at cardiovascular disease alone, you may not be able to prevent. You are going to look at diabetes. You are going to look at all the conditions. And at the stage when you are looking at them as diseases that are, already matured, or diseases that are in the grown-up population, they've gotten to a stage where it's difficult to reduce their numbers. Very, very difficult, because they come with a high cost, and there's a burden. They put a huge burden on us, our health costs and so on. You can imagine going to the hospital, hypertensive patients, and all the kind of non-communicable disease patients that we have in the hospital. Just imagine and we are going to be treating them and having cost mitigations and so on. So it's so hard. But if we start looking at it from an earlier stage, we can nib in there, but reduce the numbers that will get to that stage, because the cost effectiveness is important. We need to look at it. So we need to look at the various ways by which you can prevent and control the NCDs. And these are some of the things I have mentioned. We need policies. We need policies that will go far beyond just the prevention of adult stage non-communicable disease. Policies for adult stage, looking at hypertension, looking at diabetes, what do you call it, and all those things, and by and large, or far inadequate. We need to look at policies that start from pregnant women, looking after pregnant women so that they have everything nutritionally. The child develops very well with all the organs intact, with minimal exposure to the causations of non-communicable disease. Now, let me just, before I even proceed, let me say something which I have not said already. The mechanism, the underlying mechanism or underlying factors for causing non-communicable disease have been zeroed down to two things. The first is the presence and proliferation of inflammation. Now, I'll say it again. A lot of people will read and come across this inflammatory. That's why most of the conditions are called inflammatory diseases. Non-communicable is actually inflammation-related diseases. Inflammation is a normal physiological process, but when it persists, when the inflammation persists, it usually starts with a low tone or low order inflammation. But when it persists, when it continues, then it leads to these non-communicable disease. Inflammation is a normal response of the immune system. If you have the immune system responding normally to agents or materials that are foreign to the body and so on and so forth, they provide a certain inflammatory state where there's an increase in certain cytokines, inflammatory cytokines, which lead to increases in some other systems, inflammatory system substances, which are all produced by the body and so on and so forth. And they stem the tide of whatever is causing the inflammation. But if that is not, the low-grade inflammation is causing, not able to eradicate the agent, then you can see it persists. The inflammation will persist. And what inflammation does in that is that in the long run, when it's persistent, it also has effects, detrimental effects on the body. And these detrimental effects is what leads to the non-communicable disease. All the conditions I've spoken about have got underlying inflammation as part of the cause of those conditions. If you expose yourself to a lot of substances, environmental substances, food substances, that will lead finally to increase the inflammation in your body, you are most likely to get one of these non-communicable diseases. They all have that underlying factor. The other one is what we call oxidative stress. Oxidative stress. Inflammation and oxidative. These two are the basic underlying factors for non-communicable. Oxidative stress comes about because your body has need for oxidation. It's one of the ways by which your body's immune system also functions. It needs oxidation, which is brought about by oxygen, the presence of oxygen in your body, and then also the existence of iron. Iron as a metal is used in the oxidative processes in the body to kill agents, foreign agents that invade your body. There's a lot of oxidative substances that are produced. So you need, these are oxidative reactions that are very useful to the body. But when they go too far, your body cannot sustain them. It leads to destruction of cells, of tissues and so on. That is all that is happening in the etiology of non-communicable disease. So you need something we call antioxidants. You see, antioxidants are very, very useful to keep the oxidative stress under in a balance, or in a state where they do not conform or they don't go on to cause some of these non-communicable diseases. That's why you need a balance of oxidative materials and then anti-oxidative materials. It's very, very critical in the body. You need to have that balance. So even when you are looking at substances that you need to take into your body to control non-communicable, you have to look at the intake of anti-oxidative substance, anti-inflammatory substance, antioxidative substance, antioxidants. We have all of them, especially in our foods. Anti-inflammatory, antioxidative, they are in our foods. But what we are exposing ourselves to most of the time are the oxidative, those that increase oxidation, those that increase inflammation in our bodies. That's what we are taking in. All the foods you consider. When we look at this control using the foods, we look at the various foods, you will begin to understand some of the foods that we actually need. These are the basic underlying causes of non-communicable disease. All of them, the basic is the inflammatory process, and then the oxidative stress. So these two, if you look at them critically, and we want to look at how to control them, then we must find out what we have to do as a group, as a nation, and as a people, as a population, how we are going to reduce it, or even, if anything at all, prevent it from happening in our bodies and in the population. So basically, that is some of the things. I would like to end here, so that if there are questions, we will look for questions and see how we can answer.
Wow.
Yes.
Thank you so very much, Prof. Paul Ayi, for this elaborate and in-depth presentation on non-communicable diseases. I mean, it has one with those in mind, you would have learned one or two things that you otherwise may have glossed over. So we have heard a lot. It's now time for clarifications, questions, feedback, contributions. So if anybody has a question that you would like Prof to elaborate on, please do feel free, and then raise your hand. I'll give you the opportunity to share your question or your contribution. And so the floor is open for discussions, if any. Thank you very much. Hello. They can hear because I can hear you. I think we are delayed. So attendance sheet. Percy, can you please share the attendance sheet? I don't have it.
You check your WhatsApp,
Yeah.
but I can share it.
Okay.
I've just shared it in the attendance sheet in the chat.
All right. So
Felicia, can I ask a question, given that the The gathering is very quiet.
Yeah, go ahead.
Prof, thank you very much for the very elaborate presentation. This is Percy here. So I was just reflecting on the issues you had raised, and I was asking myself, from your experience, how much of the data on non-communicable diseases do nutritionists and dietitians contribute to? How I mean, what fraction or proportion of the data that we refer to is generated from our professionals? Is this something you can respond to? And if it is high or low, what can we do? What should be the ideal situation?
Okay. Hello. All right. Sorry, this challenge I'm having. Yeah. Yes. All right. So okay. This is a very good question. It's a very, very good question. And I think we are the ones mainly on the platform now, nutritionists and dietitians. Now, and the question that Percy, we should ask ourselves is an important question which we should all be asking ourselves. The fact of the matter is, this is the reason why we are organizing such a program. Many of us do not even want to look at that aspect of nutrition, or should I say that aspect that affects us mostly. Now, this particular issue, if we were saying that we're going to talk about non-communicable disease, I'm sure people wouldn't have even been part of it. But the fact that we said we're going to look at foods and indigenous foods and whatnot that help in communicate, or should I say, in reducing or managing non-communicable disease, a lot of people are interested because it has to do with food. But I can assure you, as nutritionists, we should be so much interested in those factors or those conditions that are influenced by diet or nutrition. And non-communicable diseases are very, very critical for us. All the conditions we try to manage, diabetes, hypertension, strokes, whatever, in the hospital that they bring to the dietitians are non-communicable diseases. So if you don't want to know the etiological factors and what actually underlines or underpins these conditions, then I don't know what you are going to be doing. You're just going to be like somebody who's just applying something without any basis. Now, I personally believe in having a basis for most of the things we do. So I've gone around, maybe because of my everything to these things. And that is the basis for our nutrition. We should know that nutrition affects our body in also many of the physiological aspects of it, the biochemical aspects of it, and the anatomical features are all influenced by our nutrition. So if we don't want to go there, then I don't know what kind of nutrition we want to do. So that is why I think we have not contributed. As far as Ghana is concerned, the contributions to this particular topic is almost zero. We look at hypertension, yes. We look at diabetes. These are the main things we look at. Maybe a few things, cases of cancer, we look at it. But to look at them together and to put them together, to look at it as a conglomerate, as being contributed by, or being a contributory factor from the various facets of our nutrition, we do not want to look at it. We don't look at it that way. I think this is just going to be an eye-opener. So all of us will begin to now see non-communicable disease and the conditions that underline them as part and parcel of what we are doing. When the dietitian is going to counsel or going to look after a person with any of these knowledge, he has to look at it from a holistic point of view. But we need, besides that, we need data. We need a lot of data, like I said, evidence. And so it's up to us to begin to now work in that area, to now extend our research tentacles towards that direction. Look at all these things. By nutritionists and dietitians, the first 1,000 days, the relationship between some of these the non-communicable disease and the first 1,000 days. They are mostly written by nutritionists. And even the other inflammation and other cases that I've been looking at are also nutrition related. So there are a lot of nutritionists on the this, and we need collaboration, not do it all. You need a collaboration between us, and so you need that collaboration to be able to be more initiative in what. Thank you very much. Thank you very much.
Thank you, Prof, for that elaborate feedback. So we need to begin to generate evidence in this area of health to improve our practice. So if there are any more questions,
Yes, I do have a follow-up.
Prof will take them for us. Please
Yes.
go ahead.
So in recent time, I've been wondering how we can use the data we collect routinely, as in the data we input into DIMS, the hospital-based data that nutritionists and dietitians collect in connection with NCDs, because we know NCDs are among the top 10 causes of death in Ghana and beyond. How can we effectively use the data that we are already collecting, even before we get a chance to start new, fresh projects or researches into NCDs from the nutrition space? How can we use the data we're already collecting in the routine data sets, the DIMS, for example, and the hospital-based management systems, health management records? Do you have any thoughts on that, Prof?
Yeah. Yes. You see, this is also a good question, and I'll throw it back to our colleagues or our counterparts who are in the Ghana Health Service or the Ministry of Health, whichever. Those who make inputs into the team, the kind of data they put in. You see, most of our colleagues think that nutrition is just about measuring anthropometry or measuring a few parameters, trying to find out about prevalence, how many people are having this condition and so on. And that is what the DIMS actually demands most of the time. You see, it demands numbers, certain statistics. You just do it and put it in there. How many have done some measurements of children? How many of them were stunted? You put it there. You have done this. How many of them? Even hitherto, there were certain conditions that were not measured. You remember, stunting was not inputted into the DIMS until not very long ago, because measurement of height or the length was a challenge. They didn't have the equipment and so on and so forth. I remember all those things. We queried all those things before. But moving forward, like you are saying, now that we are beginning to see some of the parameters to these conditions that we know have been in existence for a very long time and are on the increase, we should know what particular data we need, even if it's not to input into DIMS, it's also to inform us, to bring it out, to inform us as a body that this is what we are seeing. It's very, very important. Now, when we meet tomorrow, we'll be talking about indigenous foods that help to nip or to help to ameliorate this condition. And when we look at these foods, you will see what we are doing and what we are not doing. It will open our eyes. I'm telling you, there are a lot of things that we do unconsciously or that we don't do when we know we are supposed to do because we lack the knowledge. You know, when you don't have that knowledge, sometimes you can't do certain things. But I believe that is the reason why we are doing this CPD, so that we not only sharpen the knowledge of our members, we also improve upon their or the ability to apply that knowledge and so on and so forth. So it's very, very important. What we are doing now is a very important exercise. But I know a lot of people we are not concerned because it's all about CPD. Let me get some certificate. Let me get some points so that I can license myself or something. You see, but the knowledge that you acquire, you need to apply it. I'm telling you, there's a lot that we can do as nutritionists. As far as I've just told you, there's a whole lot of conditions that are chronic, non-communicable diseases. They are there. but nobody is even documenting them as non-communicable. They'll say, when they say non-communicable, they're looking at only 4. In Ghana, we look at only 4 as the non-communicable disease. The rest, we don't consider that as part. And I'm telling you today, depression is a non-communicable. There are so many of them. In fact, there are over 40 of them, even in Ghana. Not in Ghana. Epilepsy is one of them. How many people have considered the number of people who come to the hospital and are epileptic as a non-communicable disease and as nutrition related? Nobody considers it. How to even manage such individuals nutritionally? People don't know. They don't care to know. You see, but for me, it is not just about managing these adult stages of this non-communicable. Looking at it, look, we have to go back to basics. Our mothers and children, the pregnant women and children, if we don't start from there to look at how we can mitigate these conditions from there, how we can treat or we can deal with mothers, pregnant women, and so on. The last time I was talking about anemia, I talked about the pica or pharynx eating, ice block eating, and so on as a major symptom or sign of iron deficiency anemia. When you see them in the hospital and they are doing those things, or you ask them how many of them are doing this, you have to do a good job and bring them up to speed because it has contributions. You are eating this, you get an iron deficiency anemia. When you get iron deficiency, it has a lot of ramifications and repercussions. As nutritionists, these are the areas we need to concentrate on. So I think that it's very key. What question you have asked is very, very important. We don't just behave like zombies. We go to the DIMS, input, they say you should do this, then you go enter, I've done it. You collect your salary at the end of the month. What are you doing as a nutritionist? So we need to think about it and rethink so that we can make a better impact in our our profession. Otherwise, we'll continue like that, like how we are going on. Thank you very much.
All right. So, okay. So Alice is online, but we have let me take Alice in. So we have Alice and Joyce. So Alice will go and then Joyce will come in. All right. Alice, please go ahead with your question.
Yeah, that's a very good presentation. Thank you, Prof. I'm just responding to what RD Percy puts up about how we can use how do we use the data. I think at our individual facilities, we can just either it's monthly, we do monthly compilation, and then that can be something that in-house we find out the trend, what is happening. Every hospital has got a public health unit and all that. We can collaborate with these people and see whether it's a public health issue that we need to do this health promotion or even screening, and then which areas we should target at the facility level. Or it can be done quarterly. I know that for nutrition, reports are sent to the region. But when it comes to dietitians, I'm not really aware how the data that is generated by dietitians are being used apart from the facility level. So I think GAND can come out and then either it is quarterly that each sector would come out with their reports, what are the key findings, and then what can we do? That can be something that we will start. Once we start presenting these and then we find a way of getting it out to the public, then attention will be given. And then how the data is captured is very important. Sometimes you go to the facilities and then apart from the DIMS or the LIMS that is already the electronic that you can maybe refer to it, notebooks that we are keeping records, most of them are incomplete. So we would have to look at how we capture data at the facility level. And those that are in the DIMS that we think should be modified, we can come together. I think GAND can lead this so that we'll come together, nutritionists and dietitians in the county or nutrition professionals, holistically look at it again and have a standardized way of reporting for our facilities, depending on the level of care, from the basic or whether it's the CHIPS compound to the quaternary facility. And that's my submission. Thank you very much.
Yeah, Alice, are you finished?
Yes, thank you.
Yes, thank you very much. It's a very sound, a very important intervention you have put in. It's actually a contribution. I don't think it's a question per se. It's a very, very important contribution. It's a question that it's an issue that goes to all of us, including those of us at the university. We should step up our game and go out there and do collaborations. There's a lot of collaboration that we can do with our colleagues in hospitals, and so on. Because there is a need for all of us, including those of us at the collaboration. If the hospitals are not capturing it, if the public health people are not capturing it for their purpose, they are looking at it from their own point of view. When they talk about nutrition-related issues, they are interested in children, mostly children, stunting, overweight, blah, blah. So now even overweight is a recent thing, but it was stunting, wasting, but I'm saying that all the conditions that are nutrition-related in terms of non-communicable disease are nutrition conditions. If you go and children are getting cancers, children are having diarrhea, they are running, they're having respiratory tract infections. These are all non-communicable that are nutrition related. Let's collect all that data. Let's put it together. You may say you're not a researcher, but that is what essentially you are. If you work in the hospital and all you do is just go and look at records and record how many people came this year, this week, and they were suffering from it, just record it and go enter the things without adding or putting them together so that you can make something out of it, then where are we heading towards? Let's put this data together. I'm telling you, I want to make all of us researchers. You can collaborate with somebody at the university or somebody somewhere who can put them together and publish and come out with something. It may not be a publication. It could be a report that will be sent to the Ghana Health Service to show them that, look, this is what is happening. It's very, very important. When our women come to the clinics and they come for child welfare clinic or, what is it, ANC, and they come there, what do we do? How do we handle that data? Look, a lot of the people, the things they come there to do are nutrition related. You must give them, they are carrying children for the sake of, and they need to know what they should be doing. They need to be doing certain things which may not be in line with what they are supposed to do, so that it can have an effect on their unborn child, which can, in the long term, affect them, in the society. And that's the conditions we are going through because we're not dealing, or we're not nipping, we're not identifying it early to resolve it, and we allow it to fester, and in the long run somebody becomes an adult with all kinds of conditions and we cannot handle it.
Okay, Joyce.
Thank you, Prof. Please, Prof, you mentioned that most of these non-communicable diseases actually starts within the first 1,000 days of life of a child. I would like to know what maternal conditions could predispose a child to these non-communicable diseases later in life, and how can we help to mitigate this? Thank you.
Yes. Thank you very much. Thank you very much, Joy. It's a very important question you have asked. Very, very, very critical, especially when it has to do with the first 1,000 days. Yes, I think you heard me. I said something like nutritional insults. I didn't say dietary insults. I said nutritional what? Insults. And it's a very important point I've made because it's mentioned in so many respects. They call it nutritional insults. And when you say nutritional insult, as to most people, it's about food or diet. Now, Farinkasa is one of them. The intake of Farinkasa is not nutritional, but it's an insult. It's a non-nutritional material. But because they are taking it through the mouth and they are eating it, it becomes a nutritional insult. Now, things like that. And there are so many other things, not taking enough energy, not having enough energy in terms of their food. It's a nutritional insult. Not eating regularly, not having food regularly, and and then taking instead. There are so many foods when it comes to nutrition, foods and practices that when we don't do or we don't teach pregnant women to undertake, becomes an insult to the child, because we need to know. And then when we look at the tomorrow, when we look at the foods, we are going to look at the foods we are going to talk about. It will be something that inimical to the practice that we give, not to intervene, not to tell mothers what they should eat and what they should not eat, what they should have a balance of, and what they should avoid, and so on and so forth, especially when they are pregnant. Because if you leave them to do what they want to do, because it says it is then they, you do the same old things, the same old results, the same standard. Birth outcomes and so on are all indicative of the poor nutritional status of pregnant women. Nutritional status is not medicine, but nutritional status. If they don't have the correct nutritional input and so on and so forth, it leads to all these outcomes we are talking about. Anemia has been attributed, or has been low amount of blood, and so on and so forth. And anemia is a nutritional issue, whether it is food related or non-food related, whether it is a chronic issue of inflammation, or it is a nutrition related issue. And that's why when we're doing anemia, I emphasize on the inflammatory part of it. And people don't understand. Inflammation is a normal physiological process that your immune system undergoes. If your immune system is basically nutrients. So if you're not giving your immune system the right nutrients or the right proper, what happens is that you have a problem. And we need to have all this in mind. A nutritionist should know, so many things. If you don't know it, it doesn't mean you are not a nutritionist. You should also go and find out. It's very important for you to find out things so that you are well versed in so many things, so that you can help yourself and help the profession. Thank you very much.
Okay, thank you very much. You have a question. So we'll take the last and then we can wrap up. Mary.
Hello. Prof, thank you for your wonderful presentation. I think, like Sister Alice mentioned earlier on, some of the data, our understanding of it, to some extent, limits us. I remember with children under 5, especially those who are within the exclusive breastfeeding, sometimes you get a child or an infant you weigh, and the child's weight or length is almost hitting the +3 or even above +3. But we are told to capture that as a normal. That child should not be captured as a child who has a problem. The child should be captured as normal. When we stop, maybe when the child moves from the exclusive breastfeeding to other, maybe now we start complementary, nature will find a way of reducing the weight. Some tactics, we say some gymnastics, we like scientifically it beats us, but that is what they say we should do. So sometimes we look at it this way because that is still within the first 1,000 days of life. So does it mean that it will just correct itself? Or doesn't it have some consequences later on? And then to add it up right now, you see that if you look at the prevalence of obesity within this preschool or what have you, you see it's increasing, it's on a rise. Where does it start from? And at what point are we supposed to take it more serious? Or do we just allow, when the child gets some stage, he will get back to his normal, but okay, he has passed through the first 1,000 days. So is the danger there or to correct itself? So it kind of beats us. Thank you.
Yeah, good. I think it's a contribution as well as a question. It's a contribution. Am I here? Am I being heard? Can you hear me? Yeah, it's a very important thing. And I think you are spoken for all nutritionists who are faced with this kind of problem. It's a widespread problem that nutritionists face at the facilities. And that comes especially with the input of figures into the teams. Now, I think I told some of my students the other time that we need to bring up nutritionists to the level of doctor of nutrition so that they understand clearly their role. Because a lot of people think that nutritionists have to play second fiddle to the other health professional. And that is why when they are told to do something, they just have to obey and do it. They don't question it. But we are beginning to go gradually, we'll get out of this. And I'm telling you, we'll get out of it. If we put ourselves to it, let's understand the underlying issues. What underlines or what underpins stunted,ness? What underpins all these factors? Now, the new paradigm that is coming up to explain some of the problems that people are having, especially during the first 1,000 days and beyond, is becoming very obvious that we need to now sit up and open our eyes very well. The conditions that happen in the womb, the materials that the child requires in the womb, if they don't have it, they will suffer it in later life. That's why we say developmental origins of health and disease. If you have a condition or you suffer a certain conditions when you are in your mother's womb, that period, and it is not resolved, you are going to suffer it. There's consequences will definitely show up. So when you see a child who is above 3 years, who is becoming overweight and obese, that condition was started in the womb. Now, I don't know how many of you are aware of the fact that obesity has even been identified. A gene has been identified for obesity. Have you heard that? They call it obesogenic gene. It is not a gene that was originally there as obesogenic gene. It's just a growth gene, a gene for growth, but has been modified because of the environmental situation, the situation in which the child finds themselves. So obesity is not a genetic disorder, okay? Or it's not a genetic order, but rather a genetic what? Disorder. So if you alter the genes, you moderate the genes, and which nutrition, the genetic blueprint that is made from the beginning is normal. But until you have moderations by environmental factors, nutrition, and all those things, you don't get an altered gene. In fact, sickle cell gene is an altered gene, a gene that comes about as a result of mutation. So it is not a normal gene. The normal gene is the AA. If you get AS or SS, there is an abnormal gene there. You are not supposed to have been having it in the first place, but because of some alterations over the years, it has become a gene. The same as obesity, the same as cardiovascular disease. Some people are prone to certain conditions because over the years, that gene has been modified. And nutrition is the major factor that modifies most genes. If you allow it to the insult from nutrition continues, most other genes will be modified and people will start suffering, will having certain sufferings, and we say, oh, it's genetic. Congenital defects are genetically modified defects. Congenital, that's in the womb. When they appear in the womb, then you see the child is born with heart attack, hole in heart, all those defects congenitally related to the heart, septal defects, and so on. They are all related to some cancers, even as start in the womb. And so the child comes out within the first few years.
I'm not sure we can all hear Prof now, but
Yes, they should be able to stand their you know, they should be able to
Where is it
coming from. It's a defect. It's a defect that could be due to and stand firm. If you have knowledge, it is to bring up your knowledge so you are powerful to be able to bring the change that you want. The change is not always in the population, it's also in the data. Or the information that we provide. No, and what we don't know. Let us look for information that will help us to be able to make the change that we want to make.
Hello, Felicia. Hello, Felicia.
So I hope I am back. The network keeps going off and on. So we are at the end of today's session, and we presentation on indigenous communicable diseases. Today we have the overview of communicable diseases. Tomorrow we'll be delving deeper into how we can manage these conditions using the indigenous foods. That in the absence of any questions, contributions, I would like to thank everybody for making time to join us, both online and in person. And I would encourage that we inform our colleagues what is about the conditions that his or her clients present with. And I mean, you may be presented with some and you are just at a loss and you look like you don't know what you're about, but it's because you are ill informed about some of these things and what to do. So let's encourage one another to join in, get information, get ourselves equipped so that we can deliver on the job as expected. So thank you very much for joining Northern Zone today. You can see that we have on the slide, on the screen, the CPD protocols from Allied Health Council. We just want to refresh ourselves with that information. Many of us don't know the changes that has taken place. So as we are within the day.
Hello. Can anybody hear us?
Yes.
Yeah, so I'm not sure that I can hear the Felicia speak. I don't know if it's only from my end.
I'm also not hearing anything.
Okay. Well. Hello, Felicia. Can you hear me? It appears your microphone is off.
Okay. Sorry. So Della, if I forget something, just chip in, okay?
I missed everything you said because you were muted for the most part.
Sorry. Okay, so we are at the preceptor point. Tomorrow, so if you provide preceptor trainings for into the points are last a minimum of 1 to 3 months, then we have 3 points there. Then 3 to 6 months is 5 points. 6 months to a year is 10 points. But then you would require that the institution that is bringing the students provide you with a letter or the facility that they have appointed you as a preceptor for training. So like, for example, UDS brings its students to us. So UDS has to, give us that letter, okay, that they have appointed us as preceptors for, training the students. Then for a particular year, then we show evidence with that letter in writing to Allied Health. Then they would waive off the points depending on the duration of the training. Are we together? Yes. So, this is something we have been doing over and over, but we haven't made use of it. So now we are aware, and then we can put in the necessaries to benefit from that. So you'll see if you have participated in examination or review of articles, once there is evidence to show that, then the points allotted is also there for us to use. Now, my experience with using these documents to get waivers is that it takes a lot of time. You would write, and then by the time the waiver even comes, it may have expired. So it is there. Let's make good use of it. But our professional body, the package that GAND has in place for us. I know that there were some concerns that came up with the registrations. We are still talking with the leadership of GAND to see how they can at least relax some of the what's the name? Relax the conditions they have so that we can have a lot more of our members coming on board, especially for this year. so that moving forward, then we know that we have this particular number of people, and then who would regularly be participating in these trainings, and also upgrading themselves. People are looking at it as GAN trying to milk, but trust me, look at the council, GAN has to pay, okay, before they are given accreditation. And I understand that the fees have gone high. And so we will be unable to do it at no fee. Members will have to pay a certain amount of money so that we can be able to offset the bills with getting accreditation. So it's not about us looking for money. Money is important for the group to grow, but it's also to ensure that we are able to meet the requirements of the council. Della, do you have any?
Yes, I actually have one comment to make. So, according to Ghanaian laws, there's a law we call the Professional Bodies Regulatory Professional Body Regulatory Act. Now, a Registration Act, which suggests that for every profession that is existing in Ghana, once you have a professional body duly registered by the state, every person who practices that profession ought to be a member of that professional body. Now, that is why everybody who goes to law school seeks to be called to the Ghana Legal Council, because that is the professional body that regulates the Ghana Bar Association, actually, that regulates the practice of law in Ghana. And that's how come everybody who goes through medical school eventually becomes a member of the Ghana Medical Association, because the Medical Association is the professional body for medical practitioners in Ghana. And the same is true for bankers, for engineers and the like, pharmacists and the like. Now, in our space, the professional body that has been registered for nutrition and dietetics is the Ghana Academy of Nutrition and Dietetics. Now, until 2019, thereabout, we didn't have any professional body at all. Now, what that means is that everybody who calls him or herself as a dietitian or a nutritionist or both, if there is any, needs to be a member of GAND. And by the arrangements of the Allied Health Professions Council, Felicia, if you don't mind, go to the very first item on the options, the membership of a professional body. So it's 4 points. It's because you are projecting. If you can just go back to that, please. I want us to read it from the page. Now, and the arrangement is that just being a member in good standing with the professional body, member of relevant allied health body, is 4 points. Now, the discussion with the Allied Health Fraternity and Allied Health Council is that this is actually going to be a mandatory category. So what it means is that, I mean, last year it was optional. So once you were in good standing, you got the 4 points. From this year and onwards, it's going to actually be mandatory. So you can get 50-something points, and if you don't have this 4 points from membership, because it's also in conjunction with the law, you will probably miss out on being able to renew your license, in spite of the fact that you may have met all the other ones which is required. So I strongly encourage us to regularize our membership with GAND and to ensure that we are in good standing henceforth. Thank you very much.
Thank you very very much, Della, for that input and clarification. So we are at the end of today's session. I want to thank everybody for coming. Della, thank you so much for the backup. Okay, so to everybody who made time to join us, we are very grateful. Prayer, and we want to specially thank Prof. I mentioned to Prof the first time that he is such a great asset to us, GAND, but especially for the Northern Zone. We couldn't have wished for anyone better. Prof is a great asset, and we appreciate him so very much for the support, the guidance, the counsel that he's giving us in the zone. God richly bless you. And we are praying for long life in good health, so that you continue to guide us to become better professionals and to uplift the image of nutrition in the zone and the country at large. So, Pastor Ima, please give us closing prayer. Tomorrow, we are starting at 10 a.m. Yes, here, the same venue. Out of Northern region, Tamale, let them join online, because we'll be looking at using indigenous foods in management of chronic diseases, non-communicable diseases. So today we have had the overview of non-communicable diseases. Tomorrow we are looking close in prayer.
Please, we are praying. Father, in the name of Jesus, we thank you for this wonderful time you have given us. We thank you for taking us through this session. We ask that whatsoever we have learned, we'll be able to keep it and give us the grace to continue tomorrow. Lead us to our various destinations safely, and let your name be glorified. In Jesus' name, amen.
Amen. And let all the saints say amen. Thank you very much. See you tomorrow at 10 a.m. Bye.
Thank you so much for the experience. And Prof, God bless you abundantly for the lessons learned.